Okay, good afternoon again, and thank you for joining us on a webinar titled Early Diagnosis and Management of Autism Spectrum Disorders, brought to you in collaboration with the Ethiopian Medical Association. Uh, this webinar is a joint effort between Yetena Weg, CME, and Disability Advocacy Team. So before we start, I'd like to say a few introductory remarks about Yetena Weg. So Yetena Weg is registered in Pennsylvania, USA as a nonprofit, and it's run entirely by volunteer members. We currently have more than 70 active volunteer members spanning across 5 different countries. As you can see from the image on the right upper hand corner, it's an image showcasing our volunteers at a recent get together. So our projects and engagements can be seen in 4 aspects. The first is health promotion, which is done via discussion and articles regarding the health of the general public, health policy and its implementation. Our second largest project is the community engagement, which is done via blood drives, inclusivity, training projects, equity projects, and fundraising campaigns. Our third and one of our largest projects is our mentorship and skill sharing, where we provide direct mentorship, soft skill, career, and professional development webinars to healthcare professionals. Our first is the continuing medical education, research, and quality improvement projects. So this is another slide showcasing our programs, including CME, mentorship, health and disability advocacy, research and quality improvement. This is another slide showcasing our health promotion team. So with our health promotion team, we host Telegram live sessions where we discuss several health-related issues with consultants. Our mentorship team, as you can see from this slide, provides mentorship and continued professional development sessions and workshops to healthcare professionals. Our health advocacy team mainly participates in inclusivity, sign language training, inclusivity SRHR trainings, blood donation drives, and previously clubhouse discussions, and continued medical education webinars such as this one. Our other engagement is in our health article writing competition, which is done in collaboration with IMSA. The fourth round was announced on September 2. So for this Roha Medical Campus, so it's Roha Health Foundation will award travel grants for 2 health article writing competition winners, whereas Yetena Weg will award health oximeter for top 20 winners and a Litman stethoscope for the top 3 winners. And the top 5 winners will also get internship opportunities at Roha Health and other partner institutions of their choice. Our other engagement is the Yetena Weg Roha Research Fellowship, which is done in collaboration with Tukur Ambassa Specialized Hospital and St. Paul Hospital Medical College. The first round had already concluded, and the second round is well underway. When we come to our CMEs are freely accessible. We invite renowned local and international speakers. For this, Yetena Weg partners with the Ethiopian Medical Association, with the Ethiopian Society of Cardiac Professionals, and the Ethiopian Society of Internal Medicine to provide continued training for healthcare professionals. We've had 39 webinars in the past year, and our average webinar attendees span from 150 to 200 healthcare professionals. And for the year 2025, we plan to have more than 30 webinars focusing on emergency, surgical, and medical case, EMT, OBGYN, ophthalmology, psychiatry webinars. So you can access our previous CME sessions by going to our Yetena YouTube channel, and you can get updates about our upcoming CME sessions by joining our social media outlets, the links of which will be posted in the chat box shortly. So in order to get the best experience in the webinar, you can send your questions to the Q&A or to the chat box. And at the end of the webinar, they will be addressed by the guest speaker accordingly. And in order to get CU certificates, you must fulfill the following set of criteria. The first is attend the whole session virtually. The second is to fill the Google form for personal detail in attendance. Make sure to provide your correct name and email in order to avoid any delays in the certification process and get 50% and above on the post-webinar quiz. So you may be able to see your results right away, but the certificate will take 1 up to 2 weeks to be delivered to your email. So we ask that you wait patiently in the meantime. So that's all about Yetena Weg. So we're also joined by our disability and health advocacy team lead, Dr. Amesias. Dr. Amesias will say a few things about our disability team, and we can introduce our guest speaker and proceed.
Thank you, Tariq. Welcome everyone to our CME. This is prepared by the joint effort of Yetena Weg CME team and disability advocacy, and disability advocacy team is currently working on making the healthcare system accessible for people with disability. We're trying to work this by providing accessible information as well as accessible healthcare services, and equipping the healthcare professionals with the necessary knowledge and skills to be able to attend such patients and provide good care. And we're glad that these efforts are bringing visible change, and we thank Dr. Fikirte for her time to provide this session with us. Thank you.
Thank you, Dr. Ramis. Yes. So our guest speaker today is Dr. Fikirte Girma. So Dr. Fikirte is an assistant professor of psychiatry, a consultant in child and adolescent psychiatry at Addis Ababa University College of Health Sciences. She earned her MD from Hawassa University and completed her specialty training in psychiatry at Addis Ababa University. She holds a Masters of Philosophy in Public Mental Health from the University of Cape Town and completed a clinical fellowship in child and adolescent psychiatry at the University of Toronto. Her work focused on maternal and child mental health, development disorders, and capacity building through task shifting in low resource settings. She has served as a co-principal investigator on several international research projects, including those funded by the NIH, WHO, and Autism Speaks. She is also a recipient of prestigious fellowships and awards, including the Affirm Fellowship, the International Society for Autism Research, and the South African Association for Child and Adolescent Emerging Research Award. Dr. Fikirte is deeply committed to advancing mental health care and services in Ethiopia through clinical practice, education, and research. So without further ado, Dr. Fikirte, it is an honor and privilege to have you with us. Please proceed and thank you.
Okay, thank you very much for the kind introduction, and thank you everyone for joining. So I think we can start. I'll share the screen first. Perfect. Okay, thank you again everyone for joining. So as described earlier, I'll be talking about early diagnosis and management of autism spectrum disorder. As we know that like April is Autism Acceptance Month, so I think it's timely to discuss about these issues. So the outline of today's presentation will be, initially, I'll try to describe a few things about autism spectrum disorder in general, like what it is, the epidemiology, etiology, the clinical presentation, and other stuffs. And it's going to be more of general thing about autism. And when I specifically talk about early diagnosis and management, I'll try my best to make it more relevant to our setting, which is, in a low income setting and a resource limited setting. What can we do in terms of diagnosing children with autism early on and providing, evidence-based interventions? So I'll start by describing what autism is. Autism is basically a neurodevelopmental disorder because usually starts early in childhood, and it has been given different names in the past times. But I think in the past 10, 11, 12 years, the word autism spectrum disorder has been more common to indicate that presentation of autism is not really similar between individuals, and there is a wide range of presentations. Some might present with milder symptoms, some might present with significant communication issues, but not so much of behavioral problems, and others might have, this repetitive, restricted interest behaviors and activities that are really impairing. But when we talk about autism, it's not really, a disease that we can cure with medication and so forth. It's just a different way of brain working in a different way from, typically developing child. And most of the symptoms that we see in children with autism are, there are two categories of symptoms that we usually see. One is a persistent deficit in social communication and interaction. And the other one is in terms of, restricted interest and behaviors. and they usually start early in life. And in order to make a diagnosis of autism, the symptoms should be present early in life. And when we see the epidemiology, I don't really have a figure for our country because of different reasons, we don't really have a prevalence study. But the US CDC, the 2020 report indicates that 1 in 36 children in US have autism spectrum disorder. And this has been, if you follow the figure of the US CDC data, seems like the prevalence of ASD has been increasing significantly in the past years. But more generally, global data indicates that autism affects 1 child per 100 children around the world. The difference might be because of, the instruments that they use, the diagnostic criteria, the setting, the data was collected, and so forth. I think it's a very common question for people to ask: is really autism increasing, or is it? Are there other factors that partly playing part in increasing the prevalence that we see? So I think the major reason for the increase could be because of use of a broader diagnostic criteria than that we used to in the past. And it seems like the awareness is improving and there are better screening tools. So kids are being identified with autism globally early on in life, which increases the prevalence rate. And also, if you see the diagnosis of which population is increasing, it's mostly population that were not receiving diagnosis of autism in the past that are being diagnosed currently. These are, women or girls, people from the minority group. In the past, they were not able to access, services, so they were not being diagnosed. And also adults with autism are being diagnosed a lot. So that could also be the case. In the Western, I think there is also a pressure to make a diagnosis so that kids could access, early intervention services. And unless they have a diagnosis, it's going to be very difficult for them to access services. So because of that, they might be pressured to make a diagnosis of autism early on. But there might also be a true increase in autism. And some of the factors for that could be, older age of parents might increase the risk of having a child with autism. And also because of, the improved health system, some kids who were born prematurely or had perinatal complications are able to survive, those insults, and they may be diagnosed more with autism. And also there might be, I don't know, these are just speculations. We don't really know for sure, but because of, environmental contaminants and pollution and so forth, there might be some epigenetic changes that are affecting, the presentation or the prevalence of ASD. But generally, we know that a diagnosis of ASD is usually given to male than to female, the ratio being 3:1 to 4:1. And it might be because of, different reasons. It might be because, autism is a manifestation of, strong maleness, they say. Like male tend to systematize, and, kids with autism tend to systematize a lot. And also it could be because females are better into, hiding their symptoms. They tend to have less behavioral issues. They tend to have, even if they have restricted interests, they seem to be typical or socially acceptable. That may be the reason why they're not being diagnosed that much. And also, the amount of problem to neurons or to the gene and everything might need to be like smaller insults might lead to autism presentation in male, while females tend to, tolerate a lot of problems before starting to manifest symptoms. When we come to the etiology, honestly, we don't really know what causes autism. There are certain things that we know that, for example, autism is not really caused by psychological factors or poor parenting, which used to be the belief in the previous times. So now we know that it's not because of poor parenting. Now we know that it's not because of a curse or supernatural causes. We know that it's not a psychotic illness, and we clearly know that it's a brain-based disorder with strong genetic factors. And we could say that 80% of the risk could be explained by genetic factors, but also, as I said earlier, environmental factors also play a significant role in the presentation of ASD. And when we see the clinical presentation, I think like as I said earlier, there are two categories of symptoms that we usually see. One is, impairment in social communication and social interaction. And the other category is impairment, not impairment, but having a restricted and repetitive behaviors, activities, and interests. So I think it's going to be very important to know what the presentation might look like in a child. So usually the social difficulties, the earliest things that you see, especially during first year of life, would be kids might have, limited eye contact. For example, when they're breastfed, they don't usually keep eye contact, which is unusual. That could be an early sign. And also, when they grow up, they may be unable to, share their interests. They may not be able to share, their enjoyment and whatever emotion they have with other people. And when you see the social and emotional development of stranger anxiety might never happen. Development of separation anxiety might never happen, or it might not be very exaggerated. It might be a bit abnormal. And when they grow up, it might be difficult for them, to initiate social interaction with other people, and that might lead to difficulty in forming friendships or in keeping friendship, because it's going to be difficult for them to understand other children. In addition to that, there's also a problem with communication. And when we talk about communication, it might be like they may have difficulty using language, basically. So language development may be delayed, but also nonverbal communication aspects might also be, delayed. They may not be able to use gestures early on. They may have limited facial interactions, facial expressions, and so forth. And sometimes parents complain that their kid doesn't seem to respond to their name. And first thing that comes to mind when someone complains of that is, could they have a hearing impairment, and so forth. That could be another presentation. And also, not only delay that you see in kids with autism spectrum disorder in terms of their language development, but it tends to be a bit abnormal in development. For example, a child with autism might be able to, say longer words or phrases that they've heard from a TV, but they may not be able to use a single word for communication purposes. Or they may be able to read early on in their life, like at the age of 5, they may be able to read words, but it's going to be difficult for them to understand what they mean. So in terms of the development of language, there seems to be some abnormality. And also, instead of using words spontaneously, they tend to repeat what others are saying. And also, there seems to be normal usage of pronouns. For example, when they want water to drink, most kids would say, I want water, but a child with autism might reverse the pronoun and say, you want water, or something like that. So these are also common kind of presentations. And the restricted repetitive interest behaviors and activities that I've mentioned earlier usually lead to behavioral difficulties. And a common behavioral difficulty that you see in a child with autism is like this repetitive motor movements. Like it could be like flapping their hands, twirling their hands, spinning, rocking, bouncing up and down, and so forth, and tends to be very repetitive. It's also, they have unusual use of objects. For example, a child, a normal, typically developing child, when he's given let's say a ball, they usually try to play with it, right? They will bounce it up and down, or they'll kick it and so forth. But a child with autism, instead of, playing with it, might stare at the ball, specific part of the ball, for a long period of time. Or whenever they're given a car to play with, instead of playing with the car like any other typical developing child, they might, turn it around and just scroll the wheels, and they may spend a long time doing those things. They also, and not only repetitive motor movements that we see, but also repetitive vocalizations are also common, like, saying a certain phrase repeatedly without, in a inappropriate context. It could be, for example, they could say, mom is eating, mom is eating, mom is eating, mom is eating, repeatedly without any reason, even when the mother is not eating. And that's one of the repetitive things that we see. And another presentation could be like, they really like things to be the same and they don't want things to change. And because of that, it's very difficult to do certain things in a different way. For example, if they're used to drinking from a yellow cup, they always want to drink from that specific yellow cup. And if that's lost, then it's good. It might lead to, a tantrum in that child. Or if positions of furniture are changed, it's going to be very disturbing for them. If the doormat is not put in a way that they're used to, that's going to make them uncomfortable, and they're going to arrange it in such a way repeatedly. And the other thing is, sensory sensitivities, which I think I didn't really write those in the slide. So kids with autism, one of the things that they struggle with is they either have, sensory hypersensitivity or hypersensitivity. So whenever they have hypersensitivity, the stimulus from the environment is going to disturb them very much, and that is going to lead to, difficulties. And for example, if someone is, grinding coffee, they may cover their ears because they can't really tolerate it, or when there is light, they might cover their ears. That's a sign of sensory hypersensitivity. But also the same child might have sensory hyposensitivity, and they might present with, self-stimulatory behaviors. Like some of the repetitive behaviors that we see could be part of the sensory hyposensitivity, like rocking themselves, trying to stimulate themselves with their hands, and so forth. And these sensory sensitivity issues might lead to difficulty with feeding, difficulty with clothing, and other issues. So these are basically the core symptoms or the core presentations of kids with autism. But, some kids have additional difficulties like cognitive difficulties, learning difficulties. And when you see, like, we don't usually do, standardized tests, but if that was done in our setting, what we usually would see would be their verbal performance would be low, but the other performance might be better. It might be the opposite for, some people with Asperger's syndrome, where their verbal ability is high, but they struggle with other cognitive aspects. And I like to mention about savant skills here because it's something that you hear and, it could be on social medias, the internet, and people talk about autism kids or autistic patients having savant skills. And I want to emphasize that the savant skills are, special skills. And compared to their overall functioning, they excel in certain aspects of their function. They may have, very good mathematical ability, very good, memory, or it could be a music or something. But I want to emphasize that savant skills are present only in minority of cases. So sometimes, parents spend a lot of time trying to look for their child's savant skill, which might be, another disappointment in journey of, raising a child with autism spectrum disorder. So it can happen. And if they're present, it's good. It's always good to, identify those and try to work on those. And we know so many people are successful, but not all people with autism have these things. And as I said earlier, autism usually presents starting from early life. But in some cases, there might be kids who lose skills that they have developed early on. And usually this happens in, the second year of life between 18 to 24 months of age. We don't really know why this developmental regression happens, but 1/5 to 1/3 of children with autism might present with, developmental regression during that period of time. And sometimes it's not really a regression, but it might be like they were developing very well, but the development plateaued. And that could be one of the reasons why, sometimes you may have heard that vaccines are causing autism in children, and there are advocates who are against, childhood vaccinating their children and so forth. It might be a coincidence that many of the vaccines are administered during that time, and also, the onset of autism could occur around that time. But I think it's important to know this information, because there are so many parents who come to the clinic and ask you if vaccine is contributing to their child's development, whether they don't really have to vaccinate, their younger children. So far, there are reasons why this kind of belief came, as it wasn't really out of the blue, but now there are so many research that are done and that have proven that vaccination or any component of vaccine doesn't really cause autism. So we can safely say that it's okay to vaccinate children, and it doesn't really cause autism, and the cause is different. So when we see the diagnosis, a comprehensive diagnosis usually starts with screening questionnaires and checklists. And most of the time what happens is parents will become concerned about the child's development, or when they go to a clinic it could be for, another illness, it could be for immunization and so forth. A clinician might be concerned about the child's development. And in the West, they usually do, screening questions and checklists. And if they turn out to be positive, they will send them for comprehensive assessment and diagnosis of autism. In our setup, we don't really have, validated, adapted, translated screening questionnaires that we can confidently use and say that this really work in our settings. But usually what we do is a clinical diagnosis. We take a very good history, including developmental history, by interviewing the caregivers. And we need to do physical examination to check if there are any problems. And in addition to history, I think direct observation of the child and interacting with the child is really important, because in my experience, especially early on, when parents are referred to a clinic for assessments, when you ask them about, signs and symptoms of autism, they may not really notice them, and they would usually report negative symptoms. But when you actually, play with the child, interact with the child, you'd be able to see the deficits and the strengths that the child is having. And you might be able to use standardized tests. Again, we don't really have any adapted and validated standardized tests that we can use. We try to see if there are any differential diagnoses that we need to rule out. For example, for someone who's not responding to his name, we need to make sure that it's not because of a sensory impairment like hearing difficulty. And Basically, for diagnosis, we usually use our DSM-5 diagnostic criteria, and we make sure that the child ticks all the boxes, and then we can safely make a diagnosis, which might not be easy in a one short visit. It might take some time. We might need to, take our time and do, repeated assessments before coming to, formal diagnosis of autism. And normally, autism is a clinical diagnosis. We don't really need to do any further evaluation. In the West, I think they usually do genetic testing for Fragile X, since it's a really common comorbidity, which we cannot really do here. So any investigation that we do should be based on indication, based on, the history, physical examination finding, and our assessment. So some of the things that we can do is, hearing assessment, which is visual assessment, because these are things that usually cause delays. And kids with autism have a higher chance of developing seizures and epilepsy. So if there are any signs suggestive of seizures, then we have to do EEG, neurologic examination, and brain imaging can be done if it is medically indicated. And most of the time, it's, as I said earlier, it's difficult to make a diagnosis of autism right away, because the presentation might mimic so many other presentations. And the first one is intellectual disability. And the difference between autism and intellectual disability is that kids with autism usually have these specific areas of difficulties with, social communication. But while kids with intellectual disability, they usually have uniform delays and difficulties in most domains of their development, like in their cognitive development, in their language development, in their motor development, social development, and so forth. It tends to be more or less uniform, but in kids with autism, they tend to struggle more with, social communication bits. And it's not really uncommon to have a diagnosis of both intellectual disability and autism in a child. In the past, when we were diagnosing, kids with classical autism with more severe presentations, we could say like 70% of kids were also having intellectual disability. Nowadays, I think that is changing, because now we're able to diagnose kids with autism who are in the milder spectrum as well. Another differential is communication disorders. I think in the community, they tend to use the word the word autism for kids who are diagnosed with autism, and also for kids who are diagnosed with intellectual disability. I remember in the past, the word autism was not much known, and most people, whenever a child is presenting with, developmental delays, they used to think that it was because of intellectual disability. Now, I think because of the autism awareness, they seem to use the word autism for, most developmental problems, which might not really be accurate. Also, we tend to get many referrals from health centers because of child's delayed language development. And not all kids who have delays in language development have autism spectrum disorder. And I know that language delay is one of, the red flag signs for autism. But in kids with only, language delay or language disorder, they may not be able to use the words, but they are able to communicate in other ways as it's appropriate for their age. Like they use, gestures, facial expressions, and other stuffs. And it seems like it's only the language aspect that is lagging. But in autism spectrum disorder, social use of language, even when kids have language, they have difficulty with social interactions. And another differential could be severe deprivation. We know that for normal child development, it's not only, cleaning the child, bathing the child, feeding the child that are important. The child needs to be exposed to, language-rich environment. They should be able to touch things, see things. They should interact with other people. And when these things are missing, sometimes a child that's growing in a deprived environment might look like someone who's autistic because they lack, this social skills. Their language tends to be delayed, and because they're not doing anything, they may be involved in, some self-stimulatory kind of behaviors. But the difference between those two is when you put this child who's being raised in a deprived environment to a rich environment, usually the symptoms tend to improve and they tend to develop normally. And in most kids, you don't usually find severe deprivation, and most kids with autism are raised in in a good enough environment. And another differential, as I said, is deafness, because when there is a significant hearing impairment, it's going to affect, one's language development. And as a rule, like many of the kids that we see in child psychiatric clinics have comorbidities. It's rare to find, a child being diagnosed with only one diagnosis. And many of the kids that we see who are diagnosed with autism spectrum disorder, they usually have additional diagnosis of either intellectual disability or specific learning disorders. They may also have additional language disorder. Many kids with autism also present with attention problems. And even in the past, it was considered like attention deficit was considered as, a presentation of autism. And before DSM-5, we were not allowed to make a diagnosis of attention deficit hyperactivity disorder in a child who has autism. Nowadays, we can make both diagnosis, and we can provide treatment for this group of population. But attention problems are very common, and when they grow older, anxiety, depression tend to be common comorbidity. And epilepsy is another common neurological comorbidity that we see in kids with autism, and usually has typical two peaks. First peak is during early childhood, and the second peak for onset of epilepsy is in the adolescent period. And when we come to the management, normally management of kids with autism spectrum disorder, the interventions, they try to teach skills for the kids, skills that they didn't develop very well, and they try to reduce symptoms that interfere with child's daily functioning. So if a child is having symptom, but if that symptom is not really harmful and if not interfering with daily functioning, it might not be something that we can work with. But if they have symptoms that are interfering with their day-to-day functioning, and if they are not able to, attain some skills that are expected from their developmental age, that's where the management usually comes. And the management could be given in different settings. There are home-based interventions where, specialized therapists go home and interact with the child, work with the child. Some interventions can be delivered in school, especially, some interventions during the preschool period are being provided in a school setting, but they can also occur, in a community setting, in a specialized healthcare setting, and so forth. And we don't, as I said earlier, we don't really have any medication or cure for autism. And most of the treatment usually focuses on, behavioral interventions and psychotherapeutic techniques that can be used. And it's going to be prescribed to the child based on, the child's strength and weakness. So the approach could use, behavioral approach based on learning theory, developmental approach by seeing the child's development and interests. But there are also specific therapies that can be provided for children with autism, like speech therapy for kids who are having difficulty with, speech, language development, pragmatic use of their language, and so forth. Occupational therapists have a place in helping kids with autism, specifically focusing on, if they're having any significant motor problems, could be gross fine motor problems, especially fine motor problems. Occupational therapists can help with that. If there are any sensory issues, occupational therapists are really good with that. And also, teaching them daily living skills as well. Occupational therapists are usually trained around that. And physical therapists, depending on, the patient's need, can also be prescribed. So as you can see, treatment needs to be multidisciplinary, and everyone will do their own job, and that would help, which is lacking in our setting because we don't really have this service. We have some of them, but they're not widely available for many parents and caregivers to access them. Social skill training groups, and it could be in a school setting with peers and so forth, usually help kids with social skill problems. And we don't really have a medication that can help with core symptoms of autism. And mostly medications that we use are to manage specific symptoms or comorbidities. So if there are comorbidities, then we can use medication. For ADHD, we can use stimulants or other medications. There is seizure, we can use seizure medications. But for the core symptoms, we don't really have one. But some of the areas where we use medication are when there is significant irritability in a child, then, and if it's not responding to, or if it's not responding or interfering with behavioral therapies, then a low dose of antipsychotic like risperidone or aripiprazole can be prescribed for this patient. Or if there is a significant self-harming behavior that is endangering, the child, that's a place where we can use this second generation antipsychotic medications. Otherwise, we don't really have, an evidence-based use medications in kids with autism. When they're not working, sometimes anticonvulsants work for some symptoms, but we usually rely on, parent education and psychosocial interventions for autism. And when we see the course of autism, sometimes symptoms might present in the first year of life, but usually, most symptoms will be present at the age of 3. Some might develop, as I say, developmental regression. And usually diagnosis is delayed because not all symptoms might be seen early on, and unless we have, unless the full criteria is fulfilled, we can't really diagnose it. And sometimes the skills might have been present initially, and because it was developmental regression, they may not really get diagnosis early on. And some people might have, non-classic presentation, like girls, children with high cognitive functioning, might be difficult, to pick them. But mostly what we consider is autism is something that you will have for the rest of your life, most of the time, if you're diagnosed with it. And some of the symptoms might improve with age. For example, social difficulties tend to be very significant early on, and they tend to improve from time to time. And also, repetitive behaviors and significant behavioral issues also improve when a child reaches adulthood. But early intervention strategies usually would help people to show significant gains and improvements in early life. And I was reading some papers that were saying, like, sometimes because some of the early interventions are very effective, some kids with autism might even, not really fulfill a diagnostic criteria for autism later in life. So early intervention is usually something that's really recommended. And the prognosis, if you read like older literatures, it usually talks about, it usually says that prognosis is very poor for autism. It's only 10% of people who are able to, live independently, like around 70% have to be institutionalized and so forth. And now that is changing. One, because we're not only diagnosing, people with classical autism who need substantial support, but also we have in autism spectrum disorder, we are also capturing people with milder symptoms who are, better to cope in the world. And we are seeing many people joining college, graduating, and being able to have a job, marry, and so forth, especially the milder variants. So prognosis is usually related with diagnosis and treatment at an earlier age. The higher the IQ of an individual, the better the prognosis is. And development of communicative language early on in life, mostly said before the age of 5 years, usually indicates a better prognosis for children with autism spectrum disorder. So that's generally about general information about autism. So what do we mean about early diagnosis? So when we say early diagnosis, it's to say that diagnosing autism, before kids enter preschool age. The literature says autism can be reliably diagnosed around the age of 2 years, which might be difficult in some settings. But any diagnosis and intervention in a very young child is considered early diagnosis and intervention, and it usually leads to a better outcome. And to diagnose autism early, I think families and clinicians need to be familiar with expected developmental milestones, and routine developmental screening is very important to pick whenever a child is lagging behind expected milestones. And I'm happy to hear that nowadays in many health centers, there are early childhood development teams that are doing developmental screening. So that would be a very good opportunity to, pick children who are lagging behind in development, and they can be assessed if there are signs suggestive of autism. And not only knowing, normal, typical development, but also knowing signs of early autism in infants and toddlers is really important. We're going to talk about that a little bit later. And because not all children who exhibit symptoms have autism, and because not all kids show all signs of, autism, it's really important to have a professional evaluation and diagnosis before, informing family members, family members about their child diagnosis, because it's a difficult diagnosis, and we really need to make sure that we made the right diagnosis. I'm saying this because sometimes we receive families who are given a diagnosis of autism, but upon close observation, it seems like their presentation was rather something else. So I think having professional evaluation is very important. And having early diagnosis helps the family to access treatment earlier, but I don't usually recommend withholding interventions from families just because the diagnosis is not made. sometimes it's really useful to provide some sort of support for families who are struggling with their child's development, because some of the interventions that we give or the education that we provide for these families are more or less similar to, education that we provide for someone with intellectual disability or delayed development. And some of the things even might help, even kids who are typically developing. So early signs of autism in infants is usually if eye contact is limited or non-existent in a child by around 6 months, I would be a bit concerned. And visual evaluation, like ophthalmic evaluation, would also be indicated if that's needed. And also if by 9 months, if a child is not really having this back and forth sharing of sounds, smiles, and other facial expressions, then I would worry about, infants' social development. Usually, even at a younger age, when you make a sound, kids try to mimic that sound. When you make when you stick your tongue, they try to mimic that thing. When you laugh, they laugh. And we have this kind of, back and forth interaction with infants, even if they're not verbal. So if we're not seeing that in infants, then I might be a bit concerned, and closer, follow-up might be good. And as a toddler, usually in the first year of life, there are going to be so many changes, but most of the changes that you see are related to, motor development, gross motor development, and so forth. And the second year of life is usually for rapid development of language. And if we're not seeing that in toddler period, we tend to be a bit worried. So if they're not babbling at the age of 1, again, if they're not able to use, simple gestures like pointing to something that they need or showing, a toy that they're interested with, if they're not waving goodbye when someone is leaving and saying goodbye, then that might indicate that there might be something around that. And if they're also not responding to their name, then I would worry. But having a hearing evaluation is also really important at this time. And by a year and a half, if they're not using words, then that would be concerning. Like they should be able to use few words by the age of 18 months. And in a typically developing child, 18 months is around the time where they have a vocabulary of around, between 50 to 200 words. And it's the time where they start, combining words and using 2-word phrases. But if a child is not, have even using single words or have a very few words, then that could also be something that worries us about autism. And by 2 years, if they're not combining words, that's also a warning sign. And at any age, if we see loss of a previously acquired speech, babbling, or any social skill, then that indicates that we have to take the child for evaluation. It could be a sign of autism, or it could be a sign of, a serious medical neurological condition that might need to be addressed. Avoidance of eye contact is a significant problem that we see at any age, but sometimes some kids will see you, but will see you by the corner of their eyes, or they stare at you for a long period of time, which makes, the eye contact abnormal. That also could indicate autism. And if they usually prefer to be alone than, mixing up with kids, that also concerns us. If they have difficulty understanding other people's feelings, and if they have persistent repetition of words that others are saying, that's also a sign. We call it echolalia. And the previous symptoms that I've described, like if they're very resistant to minor changes, for example, if they're used to, going to school in a certain route, and because of some reason you have to change that direction, and if they're becoming disturbed because of that, that's a problem. If they're really sensitive to sensory things to a point that it's affecting their functioning, I would worry about that. If there are repetitive behaviors like flapping, rocking, and so forth, we would worry about that as well. So these are things that we usually see in children with autism when they're younger. And there are two kinds of tools that can be used. Some of them are screening instruments that can indicate someone might have autism, but they're not really diagnostic. And we also have diagnostic instruments. And it's not usually recommended to use screening instruments in the community or even in the clinical settings for everyone, because it takes time. And, after screening 100 children, we're only going to get one positive. So screening everyone is usually not recommended, but screening at risk or screening kids who are showing delays might be appropriate. But we currently don't have any adapted and validated tool for use in Ethiopia. And in most cases, most people usually use MCHAT, which stands for Modified Checklist for Autism in Toddlers. And it's usually used for kids between the age of 16 to 30 months. And that's really a good age to make early diagnosis. And the good thing about that instrument is it's really available. And to be used by a clinician, if the screener turns out to be positive, then a professional can do a follow-up question and see if the child is showing other autism symptoms. And it doesn't really require any special training to administer and score, but we always have to think that has never been validated in our country, but I've seen translated versions, and it could be something that clinicians can use. But also we're in the process of trying to adapt and validate freely accessible screening and diagnostic tool that's developed by people in Africa, which might be more appropriate use in our setting. But so far currently it's not finalized and it's not available. But hopefully things will change in the future. And for adults, you can also use from online other screening instruments, but you always have to keep in mind that these instruments are not validated and they're not really diagnostic, and you can't make a diagnosis by using these instruments alone. And the gold standard diagnostic instrument for autism is a combination of this ADI and Addis. ADI stands for Autism Diagnostic Interview, and Addis stands for Autism Diagnostic Observational Schedule. They're very expensive. You have to purchase them. You need specialized kind of training to do these things. So mostly the clinical application of these instruments is not going to be that much in our setting. But sometimes in the Western, when they're doing research, they really want to make sure that when they're talking about autism, they actually have kids with autism, and they use this kind of diagnostic instruments. But in our case, I think most important thing would be doing, the comprehensive evaluation and assessment and taking time and seeing the child to make a clinical diagnosis. And we have to make sure that the DSM-5 diagnostic criteria is fulfilled, because before saying, someone has autism. And when it comes to, so diagnosing someone without providing any kind of support is basically not recommended. I'm not saying that it doesn't really have any kind of use. Sometimes for people who are struggling, knowing that their struggle is because of, a known condition that others are also experiencing might be helpful. But having a diagnosis is going to be very useful if there is an intervention that's being provided alongside the diagnosis. So if we diagnose someone early, we need to be able to provide some sort of intervention. And as I said earlier, we don't really need to delay providing support for families because of lack of diagnosis or because we're not sure of the diagnosis. I could give you an example for this. You may have a 30-month-old toddler in the clinic who's presenting because of some language delays. And when you ask the family, you also see that the child is also having some social difficulties. But when you take, a detailed history, it seems like the child lives in a condo, mostly spending the time indoor. Parents are working. He's being left with, a help, and the help usually has lots of things to do. So he's usually given some smartphone to watch, movies or musics, or he's in TV almost the whole day. And we know that not being able to, if he's not exposed, to a language-rich environment where there are people talking and so forth, we usually expect this kind of things. So we usually, educate the family about, the importance of engaging the child, spending time with the child, playing with the child, and we educate them about limiting screen time or totally stopping screen time. And this kind of interventions can be provided even if we don't really know whether it's autism or it's just a language delay that the child is presenting with, or if the child is struggling with other areas of development as well. We don't really need to be sure whether that's intellectual disability and so on before, providing some sort of support for family. Because we know that the first 3 years of life, there is a rapid brain development. And if we work on that time, the kids are more likely, to learn and to catch up, to learn skills that they lagged in achieving. And that usually helps in terms of the longer prognosis. So when it comes to specific interventions that we provide, not that we provide, again, in general, intervention can be provided directly to the child, like in the West, like some ABA therapists directly work with the child, sometimes up to 40 hours per week. They spend with the child directly trying to teach a child skills by breaking down some skills into smaller steps and specifically teaching one step and rewarding and so forth, which, as you can hear, could be time consuming, and you need to have so many people who are able to do those kind of things with the child, which is basically non-existent in our setting. But also you can provide intervention through others to the child. So you can teach parents strategies that they can use, work with the child. You can teach teachers strategies that they can do with the child. And it's advantageous because these are the people who are actually in contact with the child for a long period of time during the day. So they are more likely, to be able to practice it. And even in the long run, after, therapy sessions end, we expect that parents and teachers would be able to generalize the skills and use it for future purposes. Therapies can also be provided in individual format, for example, for the child, for a teacher, for a parent, or it could be provided in group format. For example, social skill training for autistic adolescents could be given in a group format, or parents training could be given on strategies how to help their children in a group format, which makes this accessible to many people at the same time. But also, I think one advantage of a group that we're observing is that the group tends to be a very good social support for the family. Most of the time, family feel that they are alone, they're struggling alone, and there aren't other people with similar experiences. But in group settings, they can see that others are also struggling, and they can also, share experiences. It can be delivered by specialists, which usually happens in Western settings. But if we have interventions that are provided by non-specialists, that will be very good. And later on, at the end, I'll talk about some of the things that we're doing, that we're trying to provide interventions for kids with autism by using non-specialists, meaning like teachers, it could be primary healthcare workers and so forth, and it could be given in any setting. And one of the things that we need to be aware of about an intervention is about the evidence base, because many parents, especially if they're educated and if they are able to, read from the internet and if they can Google and so forth, they usually come to the clinic with so many questions. And they will ask you if, not giving the child specific kind of food is going to be helpful, or if, doing a certain type of therapy would be useful, and so forth. So as a clinician, I think our responsibility would be to read and see the evidence base of interventions that are suggested for patients with autism. And as far as I know, like behavioral interventions using, behavioral approaches and developmental approaches, using, natural environment in play settings and so forth, they're usually effective. But other, alternative and complementary treatments that we usually hear don't usually have evidence base, and some of them might even be harmful for children. For example, some of dietary restriction could lead to malnutrition. Some of the therapies like chelation, like, what was it? There are other things that they do that could actually be not useful and also harmful for the child. And sometimes people do non-evidence-based interventions. They pay a lot of money for it, and it delays them from getting, evidence-based interventions. So I think educating parents around this area is very important. And the intervention focus has to be individualized, because not everyone is the same. So we have to see the child's weaknesses and strength, and we have to try to use the child's strength to address weaknesses. But most of the time, the interventions that are provided for children with autism focus on social engagement. That is like improving the child's, joint attention, shared engagement, like being able to focus on a person and, on an activity at the same time, so that they will be able to, interact and learn. Other area of focus is communication, because even if a child has language, sometimes they struggle using, gestures and other means of communication. So communication could also be addressed. In our country, I think major reasons why parents present to a clinic is because of language delay, and the other one is because of difficult behaviors, like they may have self-harming behaviors, they may have repetitive behaviors, they may be very irritable, and sometimes those might need to be the focus of treatment. Teaching skills is really important because of their deficits. They usually lag behind adaptive skills, and teaching them is really important. And sometimes they may have specific issues like feeding, learning, and the intervention can be tailored to those specific needs. So there are specific strategies that can be used for each things that I've mentioned above, how parents would be able to teach their child to share engagement, in social settings, how a parent can teach a child to communicate better, how caregiver can help the child have fewer challenging behaviors and so forth. And by following the child interest and by using, behavioral approaches, those things can be taught to the child, and that might lead to improvement. But we have to know that we can't certainly say that interventions will work for all children. We can't really 100% say that if a child gets early intervention, he's going to be able to speak, he's going to be able to do these things. But our aim is, to help the family and the child to function in the most efficient way that they can function based on their capacity. So our goal is to help them, function better. And we may not be able to, solve all the problems that the child is presenting with. And in our case, I think parent education is a very important component. Parents need to be educated about child development and factors affecting child development. I've noticed that many parents are not aware that they need to spend time with their child, play with their child, sit on the floor, and do all these things for their child to develop properly. Some of them are not aware, and also because of, different reasons, they're very busy, they have to take care of other children, they may have to go out and work, and the kids' behavior is difficult, to engage with. And because of these things, they don't usually do these things, and educating them around that is very important. We have to tell them what autism is and what autism is not. And we have to tell them about the cause, and we have to address misconceptions that they have. Many of the parents that I see usually blame themselves for their child's presentation. They say that it's because they're not good parents that their kid is presenting this way. They say that it's because they're working most of the time that the child is developing this kind of problem. Some of the people would report, supernatural causes, and some may have guilt. So addressing those is really important, because if a mother knows that it's not her fault, but if she knows that she can do something to help their child, that's going to help with her mental health as well, which is, if she's okay, she'll be able to provide support for the child. We also have to tell them that even if we don't really have a cure or a medication for this, there is a potential for the child to grow and improve, and there is something that they can do to help in that process. And we have to educate them about evidence-based interventions to address, specific problems that the child is having. Nowadays, we're advocating for inclusion of children with autism in mainstream education that helps them with, their social skills. They feel included. And not only about their child, but also importance of self-care for the parent. And if there are available support groups, linking them to support groups might be important. But also we have to tell them about, if they raise it, about, dietary strategies, alternative and complementary treatments, and their evidence base, it's going to be our responsibility to inform parents. So finally, I would like to, because, most of the things that I've spoken about right now, like in an hour, you can't really teach someone how to provide behavioral intervention or, some sort of therapy and so forth. So in order to be able to provide support for this group of population, we need to have people who are properly trained to provide this kind of services. And given, our country's situation, like we're in a low resource setting, parents can't afford really expensive individual programs. There are only a few people who can do that, and things are expensive for them. So WHO, I think it was probably 19 years back, has come up with a training program, which is called Caregiver Skill Training Program. And it's developed for people who are in low resource settings like ours. And it basically, what it tries to do is it tries to teach evidence-based strategies and techniques for parents, and they can use those strategies to help their children better engage, understand and improve their communication, understand and improve any challenging behaviors, how to teach them skills, and also how they need to care for themselves. And basically the format is like there are going to be group sessions where facilitators will educate caregivers about strategies. And there are, we expect to have, in addition to the group sessions, we expect facilitators to do 3 home visits, one initially to see the baseline child's functioning, and then in the middle of the group therapy around the 5th session and so forth, to see how the family is using the skills to coach them, and one at the end to help them, to generalize and use the skills in the future. So we did a pilot test previously in Butajra and Addis Ababa, and it seems like it was well accepted, it was feasible, but we're not really sure about the effectiveness, and we're running like a big RCT in Addis, and we probably will have results in a year time. And if the results are positive, that could be something that could be scaled up, in school settings or in a primary healthcare setting, where you'd be able not only to diagnose and screen, kids with developmental disorders, but also provide some sort of intervention. And having a diagnosis not really a requirement for this program, but we'll see the results in the future. So this is the last slide. So I think the most important points to take would be, no matter how much delay or difficulty a child is having, any child can learn and develop if we provide appropriate support, and they develop at their own rate. It might take them some time, but we'll be able to, see some changes. And early recognition is very important, and formal diagnosis should not really delay interventions that we're going to provide. And addressing misconceptions about the diagnosis treatment is very important, and it actually affects care. And there is something that we all can do, like as a clinician, we will be able to identify high-risk cases. We might be able to make a diagnosis or make referrals. We can definitely give psychoeducation, and parents. There's also a role for parents. Parents can do a lot, but we need to, provide guidance for parents on what to do. And teachers, like if the kids are in school setting, teachers can also do a lot to improve the functioning and life of these patients. And wherever you're working, it's very good to map services that are available for these people, because when you identify, when you diagnose, or when you suspect, it's much easier to make referrals and links if you have mapped resources and services around your area. And multidisciplinary approach is going to be crucial in this case. And in the future, I hope we'll be able to have, many speech and language pathologists, many occupational therapists, many psychotherapists, and we'll be able to provide care for these patients together. Thank you very much. So if you have questions, comments, you're welcome.
Okay, thank you very much, Dr. Fikirte. That was a very interesting and engaging lecture on early diagnosis and management of autism spectrum disorders. You've highlighted the critical importance of timely intervention, so thank you for that. We have quite a few questions so far, so I'll shortly share my screen and we can go over them. Okay, so the first question is, does previous underdiagnosis especially explain the surge in incidence? And could it be related to electronics, food, or environmental influences?
Okay, I think that's a good question, and it's a question that's being asked by so many people. And we can't really tell for sure, but most people and most literatures are saying most of the surge in incidence or prevalence of autism is because of a better awareness, better diagnosis, and so forth. But I'm sure that's not, that could explain, most of the increase. But as I said earlier, it could also have environmental causes. And I've mentioned earlier some of the reasons for a true increase in autism could be like advanced age of parents, which clearly can lead to, neurodevelopmental issues. It could also be, better services for premature infants, and these infants are surviving and thriving, so they're more likely to develop, this kind of condition. So that might also be a case. But also one explanation is, epigenetic change because of, environmental pollutants and contaminations and so forth. So that's also one of the causes incriminated for increased diagnosis of autism. And also, like, when someone is vulnerable and when they're not really being exposed to a language-rich environment, when they're not exposed with people, with kids to play with and so forth, that all could also, if someone is vulnerable, that could, push them to the spectrum. So far, I don't think there is a clear data that says electronics cause autism. But we know that if people are spending a lot of time on electronics, it doesn't really give them a good chance to, develop their language, because they usually are not actively interacting with the electronics, right? And it limits their chance to have social interaction. So they may appear to be like someone who has autism. But my expectation is, if that was caused by electronic use, if we remove that and if we, put them into a language-rich environment and so forth, we usually would see rapid improvement in symptoms. But if that doesn't happen, then probably primarily the initial presentation might be of that of autism. Does that answer the question?
Okay, thank you very much. So the next set of questions, there are series actually are related to diet. So the first is, would avoiding milk and gluten help? And is there any specific food recommendation, like a gluten-free diet for kids with autism? And is there any effect of camel milk and fatty foods in reducing symptoms for children with ASD?
Okay, so when trying to look for, the evidence base, because this kind of interventions are widely practiced, and I sometimes get family members coming to the clinic and telling me that they haven't been giving their child any gluten-containing food, any casein-containing food, because they were recommended to do that or they read about it. But strictly seeing the evidence base, it doesn't really improve signs of autism. So it doesn't really have any evidence to be prescribed right and left for anyone who's presenting with developmental delay or autism spectrum disorder. In certain cases, it might work. For example, if the child is having, food sensitivities, if they're reacting to a certain food component and so forth, for these patients, it might work. But generally, when talking about autism, we shouldn't really prescribe, this restrictive dietary interventions for all children with autism, because the evidence there is no evidence base for it.
Okay, thank you very much. The fifth question is there any role for folinic acid in treating autism?
Again, as far as I know, there isn't any specific dietary supplementation like vitamin supplements, omega-6 supplements, and so forth, having a role in the treatment of autism. So as far as I know, it doesn't really have any role. I'm not really worried too much about, supplements unless they're given, as long as they're given in, the normal recommended amounts, but mega doses is definitely not recommended because it's going to be harmful. For example, if you ask my opinion about providing omega-3 fatty acids for a child with autism, I would clearly tell parents that supplementing these things for your child will not improve the core symptoms of your child. But for any child, it might be good, to get some supplements in a normal amount that might not harm them. But in the treatment of autism, I haven't come across any evidence that says that it helps in treatment of core symptoms of autism.
Okay, thank you. The next question reads, can you elaborate more on the interesting phenomena called savant syndrome? And do we have any savants in Ethiopia based on your practice?
Okay, so savant skills are skills that kids with autism spectrum disorder have that are not in line with their other areas of functioning. And these skills might be exceptional. So it might be like they're maybe very good in rote memory, memorizing things, or they may be very good in, doing calculations, or they may be very good in, I don't know, it could be music and so forth. As I said earlier, this is not a common phenomena. You only see it in minority of cases. And in clinical practice, I've seen kids who have, some exceptional or good abilities in certain domains, but it's not something that we usually see. It's not that common.
Okay, thank you. The next question reads, what are the minimum signs and symptoms that are needed to label a child as having autism?
Okay, so minimum symptoms and signs from how many would be, the question. So according to DSM-5, the first criteria is impairment in social interaction and social communication, and it has 3 domains under it, and the child needs to fulfill all the 3 to score positive. And also from the restricted repetitive behaviors, interests, and activities, there are 4 domains, and from the 4 domains we need to have 2. So we need the whole 3 from the first domain and 2 from the second domain. And if it starts early in life and it's impairing, and if it's not really because of other conditions, then you can make a diagnosis of autism spectrum disorder according to DSM-5.
Okay, thank you very much. The 8th question reads, do we have a severity classification for autism spectrum disorders?
Yes. Yes. So after making the diagnosis, there are specifiers that we can use to add on the diagnosis. So one is whether the child has intellectual impairment or not, like if the child has intellectual disability or not. The other one is if the child has associated language impairment or not. For example, someone with Asperger's syndrome may be verbal and may not really have a language impairment, even though they fulfill a diagnosis for ASD. But also another specifier that we are recommended to use is specify the severity. So it's level 1, level 2, and level 3 autism, or you could say mild, moderate, and severe autism. And it's basically based on the amount of support that the child needs to function in day-to-day life, and both the social impairment as well as the repetitive interests and behaviors need to be rated along that line. So we usually have this level 1, level 2, level 3 autism severity classification.
Okay, thank you. The ninth question reads, can healthcare providers other than psychiatrists make a diagnosis, especially at health centers?
So I think it depends on the amount of training and amount of exposure and experience they have in making a diagnosis of autism. Generally, diagnosis of autism in the Western setting is done by a child psychiatrist or a developmental pediatrician or a clinical psychologist or someone who is highly trained around that area, because there are so many things that could mimic a presentation of ASD. Usually it's highly trained, specialized people who make a diagnosis of autism. But at a health center level, I would say it's possible to make a diagnosis of, developmental delay or developmental disability. And if signs and symptoms are very obvious in classical presentations, and if you really read well, if you see so many kids, you may be able to, reach out the right diagnosis. But mostly it's usually recommended, the diagnosis, making diagnosis is usually recommended by, specifically trained people.
Okay, thank you. The 10th question is there any gene implicated in the pathogenesis of autism spectrum disorder?
I'm not really aware of any specific gene, but genetic factors play a huge role in the pathogenesis of ASD and as etiology. And most of the time, there are de novo genetic mutations that are not really inherited, and those are the causes. And sometimes it could be because of, epigenetic changes that are passed from parents. But I personally am not aware of any specific gene that's incriminated. But we know that some genetic disorders, the prevalence of ASD is really high. For example, in Fragile X syndrome and tuberous sclerosis, the prevalence tends to be very high. But I'm not really aware of any specific gene.
Okay, thank you. The 11th question is, autism is becoming more visible in our country. So why is there such a significant lack of NGO support for affected individuals?
Yeah, it's true that it's becoming more of a problem, more people are being diagnosed. The intervention is not that easy. As I said earlier, it needs a lot of resource, a lot of specialities, a lot of dedication. So most of the organizations I know that work around autism are formed by, parents of kids with autism, and they're advocating for them because of lack of services and lack of other supports. So I don't really know the exact reason why, but I think it's because, there is less involvement of NGOs around mental health, and specifically child mental health around this area. And I think it needs a lot of resource.
Okay, thank you. The 12th question is, how is virtual autism compared to the previously defined autism spectrum disorder in terms of diagnosis and management?
Okay. So I've talked about a few things about how kids who are spending a lot of time on electronics are presenting with symptoms mimicking that of autism. Virtual autism is not really an official diagnosis, and it's not found in any of the standard diagnostic manuals that we use, be it ICD-11, be it DSM. So it's not really a formal term. But my understanding is virtual autism is caused by a child being exposed to electronics for a long period of time. And we expect the child to improve if we, avoid those things and engage the child in, social activities, which is not going to be the case in kids with autism, like actual autism spectrum disorder diagnosis.
Thank you. The 13th question is, how likely is it to pass autism to one's children?
It is heritable, that we know. If a parent is diagnosed with autism, there's an increased chance of a child being diagnosed with autism as well. I'm not aware of the exact number. Usually what happens is a child get diagnosed with autism, and when parents read about it, they tend to realize that, okay, I was actually manifesting signs of autism when I was a child, but I was not diagnosed. And some adults get diagnosis because of that. But I'm not really aware of a specific number. But in the general population, the risk is 1%. And if there is a parent with ASD, the chance is going to increase.
Okay, thank you very much. The 14th question reads, is fertility affected in individuals with autism? And are there any other psychiatric comorbidities such as lung, heart, or cancer conditions that are associated with ASD?
I don't know about that. I haven't read about that. I haven't come up across such things during my reading, so I'm not going to comment on that.
Okay, thank you. The next question is there any place for neuroimaging and EEG, the diagnosis of ASD?
Yeah, if there is any suspicion of a neurological abnormality, if there is any suspicion of, seizure-like presentations, then we can investigate the children with these things, but it's not really routinely recommended to do neuroimaging or EEG for any patient suspected of having autism. But if during history taking a physical examination, if we find anything suggestive of, space occupying lesion or anything, then that can be done.
Okay, thank you very much. We have only a few questions remaining. So the 16th question is, one of our attendees was sharing their experience. So he or she read in an SD community that the diagnostic process is lengthy and difficult to access in Western countries. So he or she is asking if you know why this is the case.
It's basically because there are only limited number of professionals who are doing autism diagnosis, formal autism diagnosis. So there is going to be a long waiting list to access those professionals. Like not every psychiatrist does it, not every child psychiatrist does it. So since the number of people who are actually trained on those things are limited, and since the awareness is increasing and more people want to get assessment, I think those are the reasons that are causing, a long wait list for a diagnosis of autism, which is the case in, in many setups. And sometimes a specific type of report is required, to access services, and people have to go through that. And since it's a must, like everyone has to go that, and that's probably the reason. Not most people are, trained on that.
Okay. Thank you. The 17th question is there any explanation for the frequent occurrence of autism among the Somali migrants in US? Is there any environmental or possibly genetic explanation?
I don't know. I haven't specifically read about the Somali immigrants in USA, so I can't really comment on that.
Okay, thank you. The 18th question has partly been addressed earlier. So regarding leucovorin, Could you share which specific lab tests or assessments should be conducted prior to administering this treatment? And are there particular biomarkers or conditions that would indicate its suitability or effectiveness?
As I said earlier, I don't think it's a formally recognized and recommended treatment, so I can't really comment on that.
Okay, thank you. The 19th question has already been addressed earlier. The 20th question reads, is there any specific laboratory test available in our country to assess the suitability of supplements?
Really, one of the supplements that's provided is vitamin D. You can do, vitamin D assay. And if that's low, you can provide. If there are any, indications of nutritional deficiencies, or if the child is not feel like the child is not really eating well and getting enough from, because many kids with autism have restricted diets and they don't usually eat fruits and vegetables and so forth. Those cases, supplements might be indicated, but it's not really as a treatment for autism.
Okay, thank you. So the 21st question has been addressed earlier. So the last question is, could you share practical tips on providing sexual education to kids in the spectrum?
Okay, I think that's going to be a difficult question to answer because one, kids on the spectrum are from a wide range of areas, right? Some may be verbal, they could comprehend well, and the social skill might not be that much affected. So how you would approach that would be a bit different from how you would approach a child who's nonverbal with minimum intellectual disability. So what I would recommend would be what kind of sexual education are we thinking about to provide for this people? What's our goal? And what are difficult behaviors that we're seeing? And based on that, we can tailor our psychoeducation, and also some of our interventions can be geared, can be individualized for, specific individuals. So it wouldn't really be, you can't really give similar kind of psychoeducation for all child with autism spectrum disorder, I would say.
Okay, thank you very much, Dr. Fikirte. You have addressed all of the questions in a comprehensive manner and in a patient way. So since time is a limiting factor, we won't be able to address the remaining questions. We'll be sharing the post CME quiz link here, as well as on our dedicated Telegram group. Okay, so the first question is, which of the following best describes autism spectrum disorder? The first choice is a genetic disorder affecting only males. The second choice is a developmental disorder characterized by difficulties in social interaction, communication, and repetitive behaviors. The third choice is a mental illness that can be cured without medication. And the last choice is a condition that only affects cognitive abilities.
Okay, so I think I have clearly described what it is at the beginning of my presentation, that it is a neurodevelopmental disorder that starts early in life, and the core symptoms are, social communication and interaction difficulties and repetitive behavior. So B is the answer, but it affects both genders, and it cannot be cured by medication, and it affects, multiple domains of functioning, not only the cognitive. It mostly affects the social communication aspect, I would say.
Okay, thank you very much. The second question is, which of the following is considered a red flag for ACD in young children? A is responding to their name by 12 months. B is imitating others' actions by 18 months. C is limited use of gestures such as pointing or waving by 12 months. And D is enjoying imaginative play by 3 years.
Okay, So I was describing early signs of autism, and one of the things that I've mentioned is not being able to use gestures at the age of 1 year. So C would be the answer. But the others are, positively worded and are things that are expected by typically developing children. So the answer would be C.
Thank you. The third question is, which of the following statements best describes the impact of early intervention on communication skills in children with ASD? A is it can lead to earlier acquisition of communication skills. B is it has no significant impact on communication development. C is it may delay the development of communication skills. And D is it only benefits children who are nonverbal.
Okay, so I think we've been talking about early diagnosis and intervention because of the benefits it has on child symptoms and development. So it's clear that early intervention leads to earlier acquisition of communication skills, including social communication skills, and it improves many symptom domains of ASD. So the answer would be A, the first one.
Okay, thank you. The last question reads, which of the following is an important intervention approach for children with ASD? A is behavior-based approach, B is developmental-based approach, C is family psychoeducation, and D is all of the above.
We also need to treat any comorbid medical, neurological, or psychiatric conditions if they're present. But for the core symptoms of ASD, we've said that behavioral based approach using, the learning theory principles, development-based approach using play and, really recommended, and family psychoeducation is also a very important component of early intervention for, the core symptoms of ASD. So the answer will be all.
Okay, thank you very much. Apologies for the interruption. I got disconnected. So thank you very much for answering all of the questions, Dr. Fikirte. So on behalf of Yetena Weg and the Ethiopia Medical Association, we would like to extend our deepest gratitude to Dr. Fikirte for delivering this insightful and interesting presentation on the early diagnosis and management of autism spectrum disorders. We sincerely appreciate your time, dedication, and valuable contribution to this vital topic. I'd also like to thank my co-host, Dr. Amesias, and everyone that has joined us thus far. Thank you.
Okay, thank you very much. It was a pleasure, to contribute. And I would like to thank, all the participants for their active participation and the organizers as well. Thank you very much.
Okay, thank you and good night.